everyone, and welcome back to season 2 of Transform 360 podcast, where science meets compassion and we explore wellness from a whole person perspective. I'm your Sabartha, founder, pharmacist, and a mental health advocate. This season, we are diving deep into what truly matters your overall health, hormones, genetics, inflammation, metabolism, and lifestyle. So many people struggle with fatigue, weight changes, sleep problems, but they never really understand the underlying causes. And today I am so thrilled to welcome Dr. Omar Akhter to the show. Dr. Akhter is a board certified internist in Austin, Texas. He completed his residency in internal medicine at New York Presbyterian Queens in New York City. He then practiced hospital medicine in New Jersey before settling in with his young family in Austin. He currently runs a membership based private practice called Medina Medicine in Cedar Park, and he's focused on optimizing hormone health through a holistic approach. Dr. Akhtar specializes in conditions like perimenopause, menopause, PCOS, hypothyroidism, Hashimoto's, and more. And his passion about helping patients achieve real lasting wellness and not just treating symptoms. Dr. Akhtar, welcome to the show, and I'm so grateful that you're here.
Thank you so much for having me.
Okay, let's start the first segment with I was reading an article in the Yale School of Medicine. Like menopause is defined as a time where women they don't get their periods for at least 12 months. But the perimenopausal symptoms start at least 10 years before. And in some cases, they may. And that transition period is called perimenopause. And the average age of women with menopause in US is 52. So generally, perimenopause will start in her probably early 40s. And yet, Dr. Akhtar, it's so painful when women are told that their anxiety, mood swings, weight gain, or other things are just in their mind, and no one actually tests them for their hormone panels. So when you see women in this age, what are your recommendations, and when should women actually look?
Yeah, thanks so much for having me. First of all, excited to be talking with you. So this is something that I see on a day-to-day basis with my patients. And like you mentioned, menopause is pretty well defined. You have 12 months of no cycles, or in women that don't have cycles, you can check the FSH levels. And if those levels are very high, certain thresholds go up to 50 or even higher, then you can safely say that you're in menopause. So it's a very well-defined condition. Menopause, on the other hand, unfortunately is a bit of a gray area. There is a lot of mention about it in the medical literature, but it's not as well understood because its diagnosis is, like I mentioned, a bit of a gray area. Why I say that is because if you take the average age of menopause, like you said, 51, 52, and you put about 4 or 5 years plus minus there, then you're talking 45 to 55 is any time a woman can go into menopause, and generally closer to the 51, 52 mark. Now, perimenopause and perimenopause symptoms can begin a whole 7 to 10 years before that. So you're talking about early 40s or even late 30s in some instances. And the unfortunate thing is that with perimenopause, we don't really have a good lab test to say definitively that someone is in perimenopause or not. So, for example, if you take a condition like Hashimoto's, which I also see a lot of, Hashimoto's is something that is very easily defined. You check for thyroid antibodies like thyroid peroxidase antibodies and thyroglobulin antibodies. If they're positive, you have Hashimoto's. And if they're not, then you can't really say that you have Hashimoto's. So it's a very black and white diagnosis. Perimenopause, on the other hand, is not so clear. Perimenopause gets defined more so by symptoms than it does by any particular lab test. That's why women, when they go to their practitioner, and the practitioners are very just used to just checking labs and seeing those labs, and they find that those labs are completely normal, then they often will dismiss them and their symptoms, like, for example, anxiety, fatigue, brain fog, right? These are perimenopause symptoms very much so, but they get dismissed because of the fact that medical practitioners often don't have a lot of good education and awareness about these issues. If the issue is a simple, for example, like cycles being irregular, heavy cycles, missed cycles, then they're much more quicker to say, okay, this could be related to female hormones, this can be related to perimenopause. But if it's somewhat of a vague symptom, such as brain fog, such as fatigue, something else, and we can talk about some of the strange symptoms like vertigo that I've had in my perimenopausal and even menopausal patients. But if we're talking about those vague and strange symptoms, then that often gets dismissed. And that's where I think it comes onto the patient a little bit to advocate for themselves and to push the physician a little bit more to say, hey, look, my symptoms are not just in my head. And I don't want them dismissed, and I really want something done about them. And hopefully they have a knowledgeable and, more importantly, an empathetic practitioner in front of them who can deal with their symptoms seriously. Yeah, perimenopause, unfortunately, is a bit of a gray area in medicine, but I think there's more and more awareness about it now, and that's something I'm very happy about.
That's good to know. And you mentioned about some unusual symptoms. So I would
Mhm.
love to go over like what happens and what do you see nowadays that you can't find in literature.
Right. So, first of all, I think that if a woman is in the perimenopause age category, like we talked about, early 40s, mid 40s, right? As soon as they walk into my office, I'm already starting to think, okay, their age and their characteristics define what I'm already looking for, right? So, already I know that there could be some perimenopause related issues. Not always, but in a lot of instances, there can be. So, that's what my ears are looking out for. Now, if there are the typical symptoms, if you have things like hot flashes, night sweats, period changes, so shorter periods, longer periods, missed cycles, heavier periods, vaginal dryness, if you have things like that, low libido, you can often relate that to one of the female sex hormones, such as progesterone, estrogen, testosterone. But if you have other things, like I mentioned, fatigue, brain fog, joint aches and pains, just not feeling like yourself, right? Women often have this thing of, I just don't feel myself like what I felt before. And that is very difficult to define, but that's just something that they're telling you. And then it's up to you to try to figure out what exactly is going on. So that can happen. Now, some of the other interesting things, something like ear itching, for example, is a symptom that has been associated with perimenopause, interestingly enough. Vertigo, like I mentioned, in my experience, I've seen some cases of vertigo related to female hormones. And I'll talk about how estradiol actually resolved them in one case. So that was very fascinating. So there are some definitely strange symptoms. I think the point is that when you have a female in the perimenopause age range and they come to you with a whole host of symptoms, you want to, of course, rule out other things. Is it a vitamin deficiency? Is it a thyroid issue? Is it another underlying condition? But once you've ruled those things out, then I think perimenopause and those symptoms need to be strongly looked at as the condition that could be contributing to these symptoms.
That's good to know because as we're speaking, I know a friend who's going through vertigo and she's exactly in that age range. Thanks for explaining that.
Yeah. And while we're on that, sorry to cut you, but the vertigo part is very interesting because that was a patient I've been seeing for a while, I recently saw, and she's someone in her she's in her late 40s. And we've been working a lot on hormones and, the use of progesterone and everything. And as far as her vertigo went, been dealing with that from, okay, is it related to long COVID? Is it an ENT issue? So she went to multiple ENTs, had it looked at. They gave her some medications like the acetazolamide and those medications you're familiar with. And the vertigo may have improved, but not really significantly. And after a while, we decided collectively to start estradiol in the form of a patch. And we did so more, not to try and target the vertigo specifically, but to understand that she's in perimenopause, she's still struggling with symptoms, low energy, and those things. And let's see how much estradiol can help her in someone in her situation. And lo and behold, she found that 95% of her vertigo resolved within about a month or so of using the estradiol patch. So it's very fascinating. And I am constantly humbled by what I see in clinical practice because patients, you think one thing and patients can surprise you with something completely different.
Wow, yeah, that's amazing because your brain would never vertigo is like there's an imbalance in the inner ear and those problems, but you would never think
Yeah.
like how estradiol can help to combat some of those
Hmm.
vertigo symptoms. Thank you for sharing that. I hope some of the listeners, if they're experiencing any of it, would at least reach out to their providers. Another thing, Doctor, while we're here, is like bone health. Like that's another thing
Right.
that happens when they're in menopause. After 30, women lose their bone mineral density faster as compared to
Right.
men.
Yes.
So, in your opinion, why don't we talk much about bone health? Because women of this age, they have had family history of arthritis, or maybe they have rheumatoid arthritis. Everyone has some kind
Hmm.
of pains, the same way you mentioned. But why does the medical system just push them towards certain
Mm,
antidepressants, or they would characterize them as having phobias, and then we put them into L'Occitane and so
right.
many other things.
Right.
What have you seen, and what would you recommend to people who are suffering in this way?
Yeah. Yeah, that's a very important point you bring up. Bone and joint health, I would kind of put that together in the musculoskeletal category of hormones.
Mm-hmm.
And this is really important from two aspects. One is what you're talking about when you refer to aches and pains. So, and this, a lot of these conditions arise from lack of understanding of what estrogen is helpful or useful in the body for. So, estrogen, the reason it can be helpful for gut health, for brain health, and even for joint health is because there are estrogen receptors in all of those areas. And so, estrogen provides so many effects on, for example, connective tissue and also in joint lubrication. So that's why when we talk about perimenopause and eventually in menopause and the complete loss of estradiol, then we're talking about the lack of that lubrication in the joints. And that often leads to things like arthritis or things like just general aches and pains. And that's why you find that menopausal symptoms, excuse me, joint pains and aches can get so much better in menopause if you're using estrogen replacement. So that's really important. The other interesting connection that there from a musculoskeletal standpoint with estrogen is with something like frozen shoulder, right? Frozen shoulder is a very well defined entity, and that is a very common musculoskeletal uh, manifestation of perimenopause and menopause. So that's why these things can be very beneficial. And what unfortunately, in our medical system, we have been kind of conditioned to look at things in isolation, which is to look at only organ systems without looking at the whole person. And what I mean by that is that, for example, you go to see an orthopedic doctor, or even let's say your primary care physician, right? And you complain about a joint issue or just aches and pains in a particular area. They're only going to be looking at the musculoskeletal system and to try to handle that with a certain medication. And so that's the unfortunate part of things, but that's where we have to connect the dots. And that's what I try to do in the practice, is to connect the dots to say, okay, if someone is having, let's say, migraines, let's say joint aches and pains, how does that connect potentially to their hormones? And in the case of migraines, which is a different topic, but if you ask the patient, okay, when are your migraines worse? And if they mention that they're worse in the luteal phase of their cycle, then a lot of times then that can be related to a relative progesterone deficiency. And progesterone does help them in perimenopause with those symptoms. So to your question, that's the unfortunate situation that we find ourselves in, that then there the use of medication, one, two, three, to try and find the right medication, where in reality, it could just be a hormone deficiency. And that's a much better way of dealing with it. The other one thing I want to also mention to you on the topic of musculoskeletal, as far as it pertains to hormones, is osteoporosis and bone mineral density, because that's an incredibly important topic that when I work in the hospital on a daily basis, you have wards that are filled with older patients that are in for hip fractures. And so it's an older patient, they have osteoporosis or osteopenia, sometimes diagnosed, sometimes undiagnosed. They fall inevitably and they have a hip fracture. And every single day, your ORs in the hospital are filled with hip fracture repair that the orthopedics are doing. Now, if we can identify some or most of these patients many years before they develop osteoporosis and give them hormone replacement therapy to then strengthen their bones and give them good bone mineral density, because remember, estradiol does improve bone mineral density in a way that very few other things can. When you talk about the bisphosphonates and some of those medications for osteoporosis, a lot of them are intended to reduce osteoclastic activity, meaning that they are reducing bone loss, but they're not actually involved in active bone regrowth. And estradiol has been shown to be involved in that. There is a tremendous benefit that we can give patients with osteoporosis if we identify them much earlier, right when they have it or right when they reach menopause, to give them adequate hormone replacement therapy to then prevent osteoporotic fractures, because osteoporotic fractures have a significantly increased risk of morbidity and mortality. So it's a very important area to deal with, and not to mention a cost on our healthcare system as well. So it's a big burden on the system. I think we can try to avoid some of that by strengthening mineral density for these women. And it's just part of preventive healthcare. It's just same thing applies from a cardiac standpoint. If you can identify people that have additional risk factors or strong family histories, if you can identify them in their 30s and 40s, then you can do various things to then prevent a heart attack from happening so that they don't end up in the hospital undergoing a cardiac cath or then a open heart surgery or bypass surgery basically. So there's tremendous things that we can do, but yeah, the bone mineral density and the aches and pains, that question is very important. So thank you for bringing that up.
Thank you for sharing that. That's super important. And when you're mentioning this, another thing that we really don't probably realize, when estrogen and estradiol they decrease and progesterone, everything how that affects our cognition, how it affects our memory, how some people who have a family history of Alzheimer's, how those things can get potentiated. So, what would be your take?
Uh, this is another very important topic, and another one, we were talking earlier about the strange symptoms that you might experience with perimenopause or menopause. And this definitely falls into that category, which is to say that someone who is not necessarily an older person that has classic dementia, but we're talking just younger and maybe in their 40s, 45, they just don't have as sharp a memory. They just don't feel as much focus, right? Lack of focus. They feel forgetful about certain things, just subtle changes, right? Subtle changes. This can very much be reflective of perimenopause and into menopause. And so the important thing is that we have estrogen and progesterone receptors in our brain. And so they have very important functions there. So naturally, with the decline of that hormone, we can expect some effects in the cognitive realm to occur. And just like you mentioned, when those happen, then people can have a loss of function, a loss of quality of life. And eventually, when estrogen is low in menopause, then of course the risk of Alzheimer's and those dementias do go up too.
That's true. And thanks for sharing that. Another thing, and I'm like going way off my questions, and but for HRT, it was widely used in US in 1990, right? Nearly 15 million
Right.
women estrogen therapy before
Right.
started declining, because in 2022 there was a study that came out from Women's Health Initiative, and they unfortunately kind of highlighted that HRT can increase risk of breast cancer, heart, stroke, and those things. And soon after that, there were a lot of other studies that repeatedly kind of rebutted the study's conclusions, right? But unfortunately, that has never been the same. And most of the times, even when we look at patients, the first thing is, or even in our specific community, they would be like, HRT can cause cancer, so HRT can cause something else. So, what would you say in this regard to those people?
Yeah, this is a great question. It's very loaded, the whole question about HRT and breast cancer and
Yeah.
cancers. It elicits a lot of emotional responses, and rightly so. There's been a lot of fear for over 20 years about this. But in short, in a nutshell, basically, you're right that over many, many decades, estradiol, estrogen, and even progesterone, a hormone replacement therapy, was being used widely up until even into the 90s and early 2000s. Now, they did the Women's Health Initiative as a randomized controlled trials or several trials to basically understand the health needs of an aging population and to understand heart disease, stroke, and some of those things. One thing that's important to understand is that in the Women's Health Initiative, in the case of breast cancer,
Mhm.
first of all, synthetic estrogens and progestins were used. Okay. And I always make this distinction to listeners that you have two different types of hormones. One is bioidentical hormones, and we're talking about estradiol, progesterone, the exact same hormones that you have in your body. Those are considered bioidentical hormones. Now, when we talk about things like Premarin, you may have heard the term Premarin, right? Premarin is a type of estrogen that is called conjugated equine estrogen, or CEE for short. And this is basically a different type of estrogen than what is contained in your body. It is part estradiol, but then it has derivatives of estrogen actually from horse. That's where the Premarin comes from, pre-mare. So pregnant horse, and it's the pregnant horse's urine actually that they get the Premarin from. So the reason I'm mentioning that is that this study, the Women's Health Initiative, used Premarin with something called medroxyprogesterone acetate, or MPA for short. So the CEE plus the MPA, that's equine estrogen plus the synthetic progestin, that's what was used. And so very different from the use of bioidentical hormones. That's number one. Number two is that when they looked, what they did was they gave women CEE, which is conjugated equine estrogen, only in one arm.
Okay.
And those women were the women without a uterus. So for people who don't understand, when you have a uterus, in other words, you have not had a hysterectomy, then you must give progesterone in counterbalance with the estradiol or estrogen. And the reason for that is because estrogen promotes the growth of the uterine tissue, and progesterone or progestins, they oppose it. So unopposed estrogen can cause uterine cancer in that setting. So if someone has their uterus, you must oppose estrogen with progesterone. But of course, the women that had a hysterectomy before, they just gave them estrogen. Now, what's interesting is that in that arm, just the estrogen arm, they actually noticed a decreased incidence of breast cancer over time. Okay, so estrogen only gave a decreased incidence. That didn't get highlighted at all. What got highlighted was that the arm with the CEE and MPA, in other words, the equine estrogen and the synthetic progestin, that arm had a mildly elevated incidence of breast cancer, not even to the point that it reached statistical significance, excuse me.
Mm-hmm.
And even, so it was a very mild, modest increase when you add a progestin to it, which again did not even reach statistical significance. And they took that and just ran with it for some reason in a very rushed way to get out a headline. So it was very politicized. It was not a good use of the data, very politicized, to say that hormones cause breast cancer. In that was kind of the news headline, and that was what was ran with no context. You're not talking about what hormones are you talking. Are you talking estradiol? Are you talking about equine estrogen? Are you talking about progestins or true progesterone? And then you're not really quantifying that. So that caused really some irreparable damage for many women over decades now, where overnight it seemed like there was mistrust between the patient and the doctor about the use of hormone replacement. Like, why would my doctor be giving me something that causes breast cancer, right? So that's unfortunately what happened. Now, thankfully, we've had a lot of revisions. It's late, but better late than never. We've had a lot of revisions on that data to suggest that actually estrogen does not increase the risk of breast cancer. And this is something that honestly, it makes sense, right? Because breast cancer risk actually goes up in menopause, right, as you age, whereas estradiol goes down. So if your levels of estrogen are going down, why is the risk of breast cancer increasing at that age? And similarly, why aren't breast cancer rates going up in pregnancy when a woman has multiple times her regular estrogen level? So these are the things that people don't think about. And thankfully, we got some revisions about that. But the damage was that they led with a certain politicized headline for many years, which is that combination hormones caused breast cancer, and estrogen got a very, very bad reputation as a result of that. I have one book behind me called Estrogen Matters, and this is one that I would recommend to everyone to read. It's by a Dr. Avram Blooming, who does a lot of work in this, and he's written it very well about the whole misinformation around estrogen and how estrogen, not only does it not cause cancer, but he is using it to treat metastatic breast cancer. So it's very, very fascinating.
Thanks for sharing that book. I have to read that too. Thank you for sharing that. Thank you for going into details, of the study, so that hopefully it helps to kind of give people a different perspective to what they have been listening to next. And there's so many questions. I tried to squeeze them.
Yeah, no problem.
Yeah, I tried my best. Yeah, but there's still a lot that we have to ask you. Another thing, Dr. Akhtar, you mentioned about hysterectomy. In US, about 1 million women enter menopause every year with an average age of again 50, 51, 52. About 1 in 8 of women experience surgical menopause, right? And out of them, only about 15% would receive the evidence-based interventions for symptoms like hot flashes and weight gain, or sleep disturbances, another bigger one that we see. What advice would you give to women who are in this stage and they are just confused? They've been to their primary care, they've been to their endocrinologist, they've been to neurologist. What what is out there to help them?
Yeah, that's a great question. So, one thing I would say is that I coined the term, it's called the PNP model of healthcare. And what I mean by that is that typically when women go to their physician with these hormone related symptoms, they often get PNP, which is prescription and procedure. So in other words, it could be depression, it could be any symptom. They get put on or offered a medication first. If that medication doesn't work, then they get put on another one and another one. And ultimately, there is then an approach to say, okay, let's just take care of the problem by surgically removing it. Whether that's a hysterectomy, whether that's the gallbladder, whatever that is, then let's just do a procedure on it. Now, there are many instances, and I'm very cognizant of it, that a hysterectomy is needed. Uncontrolled bleeding, big fibroid. There's many causes, even just in general. So a woman can definitely get to a point where she needs a hysterectomy, and sometimes it could be life-saving for them in how debilitating the symptoms are. But I think in all ways, it's important to have a stepwise approach to that, which means that when you go to the physician first, there should always be a look at the whole person. So, how is your diet? How is your lifestyle? Can we use certain supplements, right? And that's where just a detailed look at everything comes in. Where, let's say you're talking about depression, you're talking about hair loss, you're talking about so many of these symptoms. Well, have you checked your iron status? Have you checked your vitamin D, B12, thyroid? Right? So checking all these things first, so you get all the information, and then what are the things that we can maybe change in the diet, adding in more protein, adding in more fiber, just refining the diet a little bit. Lifestyle is very important, as you know, when we talk about more movement, when we talk about less stress, when we talk, now these are things easy to say, but when it comes down to it, it's still very, very important. Now, when you address those foundational things, then you come on to, okay, what kind of treatment plan can we offer these patients? And I try to use supplements as much as I can. Again, just focusing on gut health and using a good quality probiotic and various other supplements that someone else might need. Then, when it comes beyond that, we have hormone replacement therapy. We have this very, very useful tool that we can use in order to improve the health of our patients. So, for example, like you mentioned, sleep. When someone has poor sleep, we can always look at something like progesterone, right? If they're struggling with perimenopause or menopause, even if they don't have a uterus, because the problem that a lot of people face is that once you say that you've had a hysterectomy, then progesterone seems to go out of the window, because it seems like its only benefit is for opposing estrogen at the uterine lining level. And that's not the case. Progesterone, like I mentioned, has a lot of beneficial effects in the brain. So progesterone can be incredibly effective as a brain hormone as well. So improved focus, better sleep, more calmness, less anxiety. All of those things can be better with progesterone. So progesterone is something that should be offered to most women as a first option in perimenopause, and even in menopause, that can be incredibly effective. Hormone replacement therapy, otherwise, we talked about estradiol, obviously, and that can be incredibly helpful from the standpoint of even anxiety is another one. I know we think more anxiety in terms of progesterone, but I've had a few patients where estradiol was actually the missing piece for their anxiety as well. I can tell you, I was working with funny enough, a mental health therapist who deals with clients with anxiety all the time. And she herself had a lot of anxiety, and we were using progesterone, and again, using that as the first hormone. Then when things got very bad and nothing was working, then we decided to use estradiol again as let's use this because you're in perimenopause and we can see how much it can help you. And her anxiety got significantly better or completely resolved in that situation. So it was very, very insightful that sometimes these things can be solved by estradiol. So hormone replacement therapy, yes. And then I think, so to answer your question, I think what it is that patients really have to just advocate for themselves. I think when they get an option if they're told like, okay, you just need a hysterectomy, I think that isn't a good enough answer. I think some nuance is needed. Okay, what can I do to prevent a hysterectomy? How necessary is this? Because again, you're going through a surgical procedure and you want to be aware of all the risks and benefits and what else you can do. And in all instances, you want to exhaust all possibilities before coming to the need for surgery. So that's the way I see it.
Okay, that's amazing, and thanks for going into all the weeds of it. I really appreciate it. Next, another thing would be most people ask is there age when HRT won't help them, or anything would not help them because they're maybe postmenopausal, or they would not benefit, or maybe they think they're too late? What are your
Yeah.
thoughts?
Yeah, that's a good question. Basically, there is a 10-year cutoff that we consider that there are significant benefits of starting hormone replacement therapy within 10 years of the onset of menopause. In other words, if you're going into menopause at 51, then starting HRT, the sooner the better, but starting it before 61 confers added benefits in terms of long-term health, bone health, all of those things, as opposed to starting it. However, that said, that doesn't mean that if you're in your early 60s or you're past 10 years of menopause, that you cannot benefit from hormone replacement therapy, both in the form of estrogen, in the form of progesterone, in some cases, if testosterone is needed as well. So there's a lot of benefits to it in symptoms, so symptom benefit, and then also, of course, long-term benefits. We talked about osteoporosis earlier. And so, if you're thinking about someone who at the age of 75 might fall and develop a hip fracture as a result of osteoporosis, then what is the benefit? What is the effect if we were to put that person at the age of 62 on hormone replacement therapy, on estrogen, essentially, and improve her bone mineral density? But if we have that mindset that, oh, after 60, 62, I'm not going to really benefit from that, then you would be preventing those beneficial situations like osteoporosis, bone mineral density, and those things. So earlier is better, I would say, but that doesn't mean you can't get benefit later.
Okay, that's good to know. If anyone out there is just thinking or is on the edge, you should consider a perspective that Dr. Akhtar just shared. That would be really helpful. Next, I would love to talk about PCOS. Maybe I'll just slightly touch it, and next time I would love to have you again where we can talk about hormones in men and maybe some PCOS. I think that's another thing that is less talked about. So, Dr. Akhtar, for like PCOS, we know it's a hormonal disturbance in women of reproductive, right? And it is estimated about 6 to 13% of women and undergo through it. And about 70% of the cases are never diagnosed. And so many women in this stage, I know it's a very big topic, are just told to lose weight. Unfortunately, the problem is that their hormones are making it hard for them to lose weight, and we don't talk about insulin resistance as well.
Right.
Your thoughts? I know it's a big topic.
Yeah. So PCOS in a nutshell, basically. So this is another area that I'm passionate about, PCOS. Typically, the other demographic that I see outside of patients that are older in their, like 45, 50 in perimenopause, menopause, the other side is much younger patients. So we're talking late teens and early 20s.
Mm-hmm.
Now, a lot of what happens is that when these essentially young girls and then into early young women, when they go to their physician, they primary care, OBGYN, and they mention symptoms like fatigue, unexplained weight gain, irregular cycles, right? Those things. Really, there isn't as much of an investigative effort as we would like to. And a lot of times there's this reflexive use of birth control, is to say, just a 16, 15-year-old, just get on birth control and that will take care of all your problems. And yes, when you have heavy bleeding, irregular cycles, oftentimes birth control can help. But at what cost? And at certainly, what underlying conditions are you missing? And I've had patients like this even recently where they're just coming into me and they've been on birth control now for 6 months. Maybe she's 17, 18. And when you talk about the symptoms, again, like I mentioned, irregular cycles and those types of things, then you think it's an easy screen to do. You should be getting androgen levels. Okay, so androgen includes testosterone, DHEA sulfate. That's total and free testosterone, DHEA sulfate, and then getting FSH levels, LH levels, right? So in PCOS, what you typically see is a high androgen, right? So you got high testosterone, high normal testosterone. You got oftentimes a high DHEA,
Mm-hmm.
and then you have a high LH to FSH ratio. Okay. Mm-hmm. And the reason for this is because at the level of the ovary, you're not having a great conversion of estradiol, of testosterone into estradiol. That's not happening well because of the enzyme aromatase. Aromatase is not effectively converting that. It could be a genetic cause, it could be environmental factors, but in the end, you're not converting testosterone effectively into estradiol. So what you are left with is high testosterone, low estradiol in general, The low estradiol then respond, the LH receptors then respond to that low estradiol, and then they cause high levels of LH, which is luteinizing hormone, which is a brain hormone. So that's what you tend to see in labs. And then you have a whole host of issues. And some that we don't even talk about is like circadian rhythm abnormalities. You can have gut microbiome disturbances, right? This is all associated with PCOS, and very, very important. So and then for a diagnosis, sometimes the diagnosis can also be gray, but generally the diagnosis is understood as high androgens, number one. And then you could have either irregular cycles, or you could have cysts on your ovaries through an ultrasound. And if you have the high androgens plus one of these other two, then generally you have the diagnosis of PCOS. Now, I do also see a lot of patterns that are like, okay, high LH, FSH ratio, high androgens, but maybe regular cycles or something like that. But in any case, the PCOS is a very, very important condition. It's the leading cause of fertility in women. So, it just surprises me sometimes when they have fertility testing or they're doing IVF and they're not screened for PCOS properly. PCOS properly. So it's just really important for us to look into, and it's very simple to do blood tests to find that. And there's then certain things that you can do in terms of diet, lifestyle, and supplementation to try and improve PCOS.
Thank you for sharing that and going into all of the details. Next time it has to be like a bigger. Yes. So next, we have a few questions from our listeners. So I would love to hear your insights, and then we'll do a rapid fire round, and then you're free to go. The first question would be, Dr. Akhtar, how do you see prescription medications fitting into a holistic lifestyle-based approach to managing chronic illness?
It's a very good question. What I would say about that is that we have to be open to the use of any and all modalities as much as possible when dealing with patients. And so my approach is try to keep it very balanced. In other words, I'm not jumping to prescriptions oftentimes initially, right? We're always trying to use a foundation of diet, lifestyle, certain supplements, and then if needed, going to prescriptions after that. So a good example is, for example, in patients of mine that are have really bad mental health and are depressed. Okay, we've looked at things like vitamin D, iron. We've tried to optimize those, testosterone, female hormones, right? But they're still struggling, and it's a real bad struggle. Well, a lot of times maybe a low dose Lexapro or something like that can be very helpful and can really change their life. And so I'm certainly open to that. The other thing these days, which has become very important, is the Mounjaro, which is the tirzepatide, and these types of medications, which I have also been much more open in using, in that if you try to lose weight through diet, lifestyle, you're doing everything right. And I've had patients where I've been working with them for over a year, sometimes 2 years. We're trying to optimize hormones, doing everything that we can to try and lose weight, but that weight is just very resistant, and it's accompanied by other inflammation symptoms. And then we decide to use tirzepatide. All of a sudden you have good weight loss and you have improvement in energy and reduction in inflammation. So we have to be open to using that. I think that there is a place for these prescriptions in a holistic practice, and so it shouldn't be one or the other. I think both is very important.
And that's such an important perspective. And I think weight loss is another beast in itself. And the next one would be, what advice would you give to today's medical students who want to practice more patient-centered and root cause medicine?
Another great question. I think that if I could tell myself a lot of these things earlier in my medical career, I think that would be really, really helpful. I think, again, coming from such a traditional way of learning, both in medical school and in residency, where you're taught things like, if you have diabetes, that's just going to be a chronic illness that you're going to have for forever. Whereas after my residency is the first time that I ever heard of the concept of trying to reverse diabetes and insulin resistance, So I think taking an approach that doesn't subspecialize too early is really important for medical students. Now, there are certain specialties that require you to be very subspecialized. Of course, like a neurosurgeon, he has nothing much to do with hormones, right? So, at least the female hormones and these things. But so they have a very different skill set that they need, and that's understandable. But I think also at the same time, you can be a very well-rounded physician too. Like I just mentioned, orthopedics and osteoporosis. Imagine if orthopedics were very in tune with hormones and they could prescribe their patients estradiol if they had osteoporosis, how much of a beneficial preventative measure would that be? So I think it's knowledge about this and hormones is incredibly beneficial for all physicians to have, especially younger physicians.
And I think that that's an amazing, practical, and inspiring advice. And I hope so many aspiring doctors would take that to heart. Next, the second last questions. What experience in your training or career most shaped you into the compassionate physician you are today?
Okay, that's a good question. I think that honestly, the very reason that I went into medicine is to try and, again, we go back to helping people, right? I think that we sort of lose that when we become physicians because then it becomes about pursuing the science, then it becomes about money, then it becomes about prestige and accolades and things like that. But ultimately, a lot of people do go into medicine, at least early on when they're younger, to try and help people. And so just trying to remember that's the reason you're there every day, that helps me to try and to start with compassion. I think that when you're dealing with people that are struggling, then they're coming to see you, seek you out, pay you, and so the least that you can do is be compassionate towards them. So I don't know if there's any one particular thing. It's just kind of the way that I've thought about it through my medical career.
And that's beautiful, and that tells you, how your mindset is. And it is very important to remember why you started doing it, so your why is always significant. The last question from the listeners would be, what do you believe sets your practice apart from others in functional and integrative medicine?
These are great questions. I would say that with my practice, what I'm trying to achieve in the practice is really merging the best of all worlds, right? Where we're talking about, okay, a holistic practice. So first of all, trying to incorporate elements of diet, lifestyle, those foundational things, supplementation, along with the utilization of medications and prescriptions. So sometimes that's not easy to find because someone is on either extreme of that, only using prescription medications, only using a holistic approach without the ability to prescribe. Other people also don't want to sometimes see nurse practitioners or PAs, and I understand that. So trying to be an MD that deals with that and deals with, kind of merges the best of all worlds, that's one. The other thing is that even though it is a membership based practice and it is outside of insurance, I'm still trying to be as affordable as I can within reason, of course, which is that compared to many other physicians around town and perhaps many other areas where they're charging thousands and thousands and thousands of dollars, I'm trying to be much more affordable in a membership based practice that the average person can still afford. So it's not really for rich patients only.
That's true.
So essentially just trying to merge the best of both worlds, trying to make it affordable, trying to give patients trying to listen to patients. I've never had a situation that I've had to cut a patient off because I've always had time with them. So giving them time, giving them attention, being very quick to respond to them, those types of things.
That's true, and I think that's the main thing that unfortunately we don't listen to people. So I think that's the best thing, that you give them time, you listen to them, and they feel that they're seen and heard by you.
Right.
The best way.
Right.
And I still have a lot of questions, but I think yeah, it's a question from me, because I know you mentioned about your traditional training in medicine, right? What made you move towards getting to the root cause or getting more training into the functional health side as well?
Yeah. This is basically just my experience in residency, I would say. When I was first working here in New York as a physician in the inpatient setting, again, doing an internal medicine residency means that you are basically inpatient, right? So seeing a lot of hospital patients. Just seeing the number of sick patients that I felt, okay, they're coming in with one acute issue and I'm quickly trying to wrap a band-aid around that as best I can and then getting them discharged and moving along. It just didn't feel right to me. I wanted a situation where I could spend more time with the patient. I can actually help and heal that patient more. And so that's where, and develop a relationship with them and things. So that's where the idea of more of an outpatient practice and more of a holistic practice came about. And then that's what, just a progressive thing where you kind of deal with patients and you learn more and more about the nutritional world and the functional medicine world and the hormone world. So it's just a snowball effect, and that happened over time, and that's what led me to where I am.
That's amazing. Thanks for sharing that. And it's always a pleasure working with you. And now we're moving to our last segment. Now, time for a little fun. I'll ask you a quick 6 questions. Just say whatever the first thing comes to your mind. What's the most overlooked hormone?
I would say progesterone.
Okay. Biggest myth about menopause?
Well, I guess the biggest myth is the estradiol, or that hormones cause breast cancer. That probably is that one. Yeah. But there's so many though.
That's true. That's true. Most interesting thing, people are usually surprised to learn about you.
That's interesting. I don't know actually that one. Yeah, I don't know actually.
If you weren't, what would you be doing right now?
At this point in my life, I would probably be doing some type of humanitarian work.
Okay.
It's what I enjoy the most. And so some type of working with an organization that goes to different places and provides humanitarian aid and those types of things.
One thing about your morning routine that always sets you up for a good day?
Coffee.
Okay, perfect.
Yeah.
A hobby or activity you love that most people wouldn't guess?
Would contest?
It would be hard for them to guess.
I would say most hobbies, like, sports and soccer and, just spending time with the kids and everything, is pretty not that hard for anyone to guess. I think just maybe travel, and especially travel to certain for certain humanitarian causes. That would be my good, and maybe even podcasting. So I do have 2 podcasts, and that's something that people may not know right off the bat.
Okay, perfect. And as we're talking about your podcast, what are the 2 podcasts that people should follow?
Yeah, so I have one podcast that is called Better Medicine, and that is just in terms of discussing with different people about medical topics and these things. The other so that's according to everything that we've been talking about in today and in my career. The other is a separate issue. It's mostly about the Palestinian issue, and that is called Save the Olive Tree, and that's on YouTube and Instagram, and that's where I discuss the Palestinian issue, which is very close to me as well. And so that's more of a kind of history, politics, the medical side of things, and what's going on there. So that's my other podcast.
Okay, thanks for mentioning that. I'm still learning how to put timestamps, but I'll try to do my best. The last question: if you could master any skill outside of medicine, what would it be?
Right now, it's learning Arabic. So mastering Arabic is the top of my list right now.
Okay, perfect. That's amazing. Thank you so much, Dr. Akhter, for sharing your wisdom today and for helping patients seem truly seen, heard, and properly evaluated. And thank you so much. I would love to have you back. There's so many questions. There was a flood of questions. I tried to control myself. And to all of our listeners, thank you for tuning in into Transform 360 podcast. And if you enjoyed this episode, don't forget to subscribe, share, and leave a review. Until next time, take care and stay balanced. Thank you so much, Dr.
Thank you for having me. Thank you for doing this. It's really, really important work.
Thank you.